In this video, let us learn a few details about the various cranial nerve nuclei seen in the medulla. Let us begin with the hypoglossal nucleus. The hypoglossal nucleus belongs to somatic efferent column. This nucleus is located near the midline. In the closed medulla, they are ventrolateral to the central canal, whereas in the open medulla, they underlie the hypoglossal trigone in the floor of the fourth ventricle. Hypoglossal nerve fibers which start from here pass through the reticular formation on the lateral aspect of the medial lemniscus and exit along the ventrolateral sulcus in the form of 10 to 12 rootlets. This nerve supplies the muscles of the tongue of the same side. Now these muscles are developed from occipital myotomes, and because this nucleus supplies the muscles developing from myotomes, it belongs to somatic efferent column. Lesion to the nucleus or to the nerve causes lower motor neuron type of lesion in the ipsilateral muscles of the tongue. That is, we see flaccid paralysis, atrophy and fasciculations of the muscles of the same side. So to test this, ask the patient to protrude his tongue. His tongue deviates to the paralyzed side. That is because of the unopposed action from the contralateral genioglossus. Hypoglossal nerve nucleus is also surrounded by multiple small nuclei called as perihypoglossal nuclei. Now coming to the nucleus ambiguus. Now this is located deep in the reticular formation. Because its location is not definite, that is why the name nucleus ambiguus. Neurons in the nucleus ambiguus migrate forward so that they'll stay close to the source of their sensory information. In this case, it will be from the spinal nucleus of the trigeminal. So this process of migration is known as neurobiotaxis. This nucleus receives bilateral projection from the cerebral cortex. Because this nucleus belongs to special visceral efferent column, it supplies the muscles developing from 3rd, 4th and 6th pharyngeal arches. That is, the muscles of the pharynx, larynx, soft palate and upper esophagus. It sends its fibers along the 9th, 10th and 11th cranial nerves, which exit along the dorsolateral sulcus. If there is lesion to this nucleus, it results in dysphagia, that is difficulty in swallowing because of the involvement of pharyngeal, esophageal as well as soft palate muscles which are involved in swallowing reflex. It will also result in dysphonia and dysarthria, that is altered voice, typically described as hoarseness of the voice, as well as difficulty in speech due to the involvement of laryngeal muscles. The integrity of this nucleus can be tested by eliciting gag reflex. So in case of lesion to the nucleus, the palatal muscles on that side will be unable to contract and the uvula will shift away from the affected side. Please note here, in case of hypoglossal nucleus injury, the tongue will shift towards the paralyzed side, but here the uvula will shift away from the paralyzed side. Now coming to the next nucleus, that is dorsal nucleus of vagus. In the lower closed part, this nucleus will be lying lateral to the central canal and dorsolateral to the hypoglossal nucleus, whereas in case of the upper open medulla, this will be lying beneath the vagal trigone in the floor of the fourth ventricle, and here it is related lateral to the hypoglossal nucleus. Again, this nucleus receives projections from bilateral cerebral cortex. Because it belongs to general visceral efferent column, it sends preganglionic parasympathetic fibers through the vagus nerve to all the viscera in the thorax and abdomen. Now, lesion to this nucleus results in sluggish peristalsis because it will be supplying fibers to esophagus, stomach, upper, small intestine, etc. So this will result in delayed gastric emptying. The vagus will also be supplying to the heart, and in case of lesion to this dorsal nucleus of vagus, because of the reduced vagal tone, there will be acceleration of heart rate. How do we test it? We perform oculocardiac reflex or carotid sinus reflex. That is done by pressing on the eyeball or pressing on the carotid sinus. In a normal person, both of these will result in bradycardia. But in case of lesion to the nucleus, we will not be observing bradycardia. Afferent limbs for these reflexes will be mediated by ophthalmic division of the trigeminal nerve in case of oculocardiac reflex, or the glossopharyngeal nerve in case of carotid sinus reflex. And the efferent limb will be mediated by the vagus nerve itself, which will be receiving fibers from dorsal nucleus of vagus. Now coming to the nucleus of Tractus Solitarius, that is located slightly ventrolateral to the vagal nucleus in the open medulla. It serves 4 functions. The rostral part of this nucleus serves the special visceral afferent function. It receives gustatory or the taste fibers from the 7th, 9th and 10th nerves, which will be traveling as Tractus Solitarius. The caudal part of this nucleus serves the general visceral afferent function. They receive afferents from the viscera, that is from pharynx, esophagus, various thoracic and abdominal viscera, which will be reaching through the 9th or the 10th cranial nerves. Ventral part of this nucleus receives fibers predominantly from the trachea, larynx and pulmonary afferents, and that serves as a center for respiratory control known as dorsal respiratory center. And the dorsal part of this nucleus will predominantly receive input from carotid sinus and the aortic body, so it acts as a baroreceptor nucleus in case of cardiovascular regulation. Lesion to this nucleus results in dysgeusia or hypogeusia, that is altered or reduced taste sensation. Absence of taste or ageusia is a very rare phenomenon because too many nerves are involved in carrying the taste sensation. Baroreceptor reflex will also be affected. Theoretically, it should be able to test for taste sensation on the ipsilateral side of the tongue, which should be absent, but it's rather a diffuse sensation, so it will be difficult to elicit the response. Now coming to the spinal nucleus of the trigeminal nerve, it belongs to general somatic afferent column. The afferent fibers of the trigeminal nerve, when they reach the pons, they either relay in the principal nucleus at the same level, or they ascend to relay in the mesencephalic nucleus, or they descend to relay in the spinal nucleus. So these descending fibers will form the spinal tract of the trigeminal nerve. So spinal nucleus and the spinal tract extend from the level of lower pons all the way down to the second cervical segment in the spinal cord. So at the level of second cervical segment, the spinal tract will continue as tract of Lisor, and spinal nucleus will continue with the substantia gelatinosa. So within the tract, these fibers are arranged as per the division of the trigeminal nerve, that is ophthalmic fibers are ventrolateral, mandibular fibers are dorsomedial, and maxillary fibers are somewhere in between. But within the nucleus, description is slightly conflicting. Some believe that it is again according to the divisions, that is ophthalmic fibers are ventral and caudal, mandibular fibers are dorsal and cranial, and maxillary fibers are in between. But others believe that there is an onion skin type of an arrangement, that is periphery of the face is located in the dorsal part of the nucleus, whereas central part of the face is represented in the ventral part of the nucleus. In addition to trigeminal input, this nucleus will also be receiving information from the facial, glossopharyngeal and vagus nerve. The fibers will also be traveling in the spinal tract. Now, based on the modalities that is received by this nucleus, the nucleus is further subdivided into 3 parts from above downwards. They are the subnucleus oralis, subnucleus interpolaris and subnucleus caudalis. The caudalis nucleus receives pain afferents, whereas the other 2 nuclei along with the principal sensory nuclei will receive the mechanosensitive afferents. So this nucleus caudalis functions as pain gate control center for the head region. This area will also receive inputs from the nucleus raphe magnus as well as periaqueductal gray, which will help in pain modulation. In the lower closed part of the medulla, the spinal nucleus as well as its tract are close to the surface, where they form the tuberculum cinereum, So here they are accessible for tractotomy, which helps in relieving the pain in case of trigeminal neuralgia. But in case of the upper medulla, this nucleus is pushed to a deeper plane by the inferior cerebellar peduncle. So fibers starting from this spinal nucleus of the trigeminal cross the midline and ascend as the trigeminal lemniscus. So this trigeminal lemniscus will be seen throughout the pons and the midbrain. Now that will be carrying pain sensation from the head region to the ventral posteromedial nucleus of the contralateral thalamus. And from there, the fibers will be projected to postcentral gyrus, that is area numbered 312. Some of the fibers from the spinal nucleus may also project to ipsilateral thalamus. Now this nucleus can be tested by testing for pain sensation in the face along the area supplied by the 3 divisions of the trigeminal nerve. That is, you can test it on the forehead, upper cheek and on the chin. Now coming to the vestibular nuclei, they are located laterally in the floor of the fourth ventricle, where they occupy the vestibular area. They extend from upper medulla to the lower pons. This complex of vestibular nuclei contains 4 nuclei, that is medial, lateral, superior and inferior. In medulla, the inferior and the medial nuclei will be seen, whereas in pons, medial, lateral and superior nuclei are seen. Medial nucleus is the largest. Lateral nucleus is also known as de terce nucleus. We shall discuss various connections of the vestibular nuclei in a different segment. But what we can now know is lesion to this nucleus results in rotatory vertigo and vomiting. And to test for this lesion, we can conduct caloric test. That is, we introduce cold water followed by hot water in the external acoustic meatus. Normally this sets in nystagmus called as caloric response. The cold water sets in fast component of the nystagmus in the opposite direction compared to the ear in which you are introducing the water, and hot water sets the fast component of the nystagmus in the same direction. So this is typically remembered as cows, that is cold in the opposite, warm on the same side. But in case of the lesion to the vestibular nucleus, this caloric response will be absent on the affected side. So by doing this simple bedside test, we can know whether the vestibular apparatus is normal or not. So we shall discuss about the cochlear nuclei along with the pons. So with that, we come to the end of all the cranial nuclei within the medulla oblongata. Hope you enjoyed this video. Thank you. You can also visit this site for other neuroanatomy videos.